Okay. So basics of USG. So here, first, let us see what we do by USG. If we want to study a structure, we see the structure piece by piece. How we understand? We cut it in a different sections. Okay. And it is similar to CT or MRI. In CT also, in MRI also, you see the structure by different sections. You make different sections. So one slice, you understand from that. Then it is a black and white picture. Okay. Studying a 3D structure. So here, see, this is only a vegetable cucumber. So here, uh, if I want to understand the cucumber in a very nice way, in a scientific way, then what I will do, I will cut it in different sections. So what are the sections? These we can consider with axial section. This we can say this is sagittal section, and this is coronal section. Now, when you have seen the complete structure of the vegetable, then if I show you this section, it becomes very easy to understand that how I have made this section or this piece, where from it has come. Ultrasound, what it does, you ultrasound or CT or MRI, everything, what it does, you see the cross section first, and in your brain, you all together you assemble them and make this complete structure. So with ultrasound, we are doing this thing only. First, we are starting with the cross section, and then we are seeing the whole structure. Think the whole structure as a, say, kidney. Yeah, it is inside our body. We don't know that what is the structure, how it looks like, or not a kidney, a stone inside the kidney. So what may be the shape of the kidney? So we will first see in the cross section, and then we will imagine in our mind that where this structure can be. So we can, as I told you, this green one is axial plane. So this one is axial plane. This is the this blue one is like sagittal plane, and this coronal plane is red one. Okay. Now this red one we can see in MRI mainly, but in ultrasound it doesn't have any role. We cannot get an coronal section of any structure for that matter. So we go with the axial and sometimes sagittal. This okay. Another thing, this sagittal means if most of the time it is long axis and it is the short axis. Here, so studying a 3D structure, here you see how we understand that. So here, if you see that axial section, we think that this is the axial section. Then from axial section, we see the shape. Here, the lower one is bigger and upper one is smaller. So when we assemble in our mind, we understand that this structure might have been a smaller part, and that's why this cross section is smaller. Don't think about the full thing, the inside structure. Say, as I told, that it is maybe a stone in the kidney, and that is a conical sheet. So you can understand that from here also that it is earlier it was big and then it becomes small. So how it changes. Okay. So in this way, this is the, say, my probe is placed in a axial section manner. Then the same thing if I do in a sagittal section. So in this way, we are seeing and we are thinking that, okay, how this has been placed. So as I told you, with USG, it is just the reverse. From cross section, we are imagining the main structure. What problems now we may face here? Here we can see from this big vegetable that which is the upper end, which is the lower end. But when we are doing in a human body from a structure, we need to know two things. One is which is cranial side, which is caudal side. Because say this structure may be the center part and it is a completely circular thing. So you don't know which side is upper side and lower side. So two informations you always want to see by when you are seeing a cross section or sagittal section, whatever you are seeing, you need to understand which one is cranial side. Means on the screen you are seeing the picture. So screen's left side means cranial side or caudal side of the patient, right side or left side of the patient. So lateral, medial, cranial, caudal, actually right, left, all these things you need to know. Okay, this thing by seeing the picture you can never make out. So that is the thing. So here we know that which is the cranial and which is the caudal. How to solve it then? So answer is aspect marker. When we are seeing a structure, with the probe, this probe has some different markings. So these are called aspect markers. In different probe, it looks like different. In some probes, there are light, aspect marker light. Okay, and in the screen, left side, you can see a symbol. Maybe it is like a dot, or maybe it is the G company's name, or in some other company's name. So you will know whenever you put the probe, be it in a cross-sectional axial manner, or in a sagittal manner, or in an oblique view also. So you know that which side is which side. Say cranial side is left side of the screen. I mean, if I always use like that, you can use, of course, aspect marker. Always left side will remain with the go with the aspect marker. So you can do the reverse also. If you put your aspect marker in the caudal side, then left side will become caudal side. Okay. Now let us understand the orientation a bit better. So this we understood. So think this is the vegetable and I have put one stick here. Now this stick here is going like this. This yellow part we are not seeing. It is going inside. So what we can see from the direction, it must be that it is going from say this side is your cranial side. If I write it here, just a minute, annotate. So, okay. So this side may be the cranial side and this side may be the caudal side. Okay. And this side may be the anterior side and this side may be the posterior side. So what we can see? We can see that, okay, it is going from anterior to posterior. It is going from caudal to cranial. These two information we can get. But this is in the whole body. But how will we see if we see the cross section? So, okay, second picture, this one. So, okay, here we understood this much, the last one, but then next picture, here what we understand that it is not only going from anterior to posterior or caudal to cranial, it is going from right to left also. Okay, so how will we see when we see the in a cross section? We will see that say here if I mark in this way that just a minute. Okay. So here say I mark in this way 1, 2, 3. Cross sections are taken 1, 2, 3. Can you say here the most upper one is 1 or most lower one is 1? What do you think? Anyone can answer. Can you imagine that these red spots? Think about the stick. This stick, when I am seeing a axial section, this stick has become a spot. It is like a spot only. It is a small dot. It is a small dot. So this 1, 2, 3, from 1 to 3, when these axial sections are taken in this way, then one must be the lower one, because you can see if this is the anterior side and it is the posterior side, then one corresponds to much posterior side and 3 corresponds to much anterior side. Okay, and this is about 2. Okay, so this is what I am talking about, that if you see the cross section, say here you think that inside the body this is a artery. So you know that this arteries flow this in the place of stick. By seeing this artery you can know that, okay, artery is flowing from anterior to posterior, and it is in axial section you will see like this. Okay. Okay. So here also, as I told you, so in this section, what will happen? So in this section, you will see that here you see when I have made the section, the second one is cutting the this your this stick, yellow stick, it is cutting. But the first one, the leftmost line, it is not even cutting, and the third one is also cutting. But then third one is, so here which one is third one? Here it must be this one, must be the third one. How do you understand? Because it started from here, so it must be superficial. It is superficial, and here so from here it is the third one because it is superficial, and the second one is this one because it is coming a bit deeper. It is a bit coming deeper, and first one doesn't have this spot. Okay. So from this slide, actually what I want to say you that while seeing the structure, please try to imagine that how the structure can be. This is our main aim while we are doing the ultrasound. By seeing the bony contour also, you must be able to understand that how the bony contour should look like, whether it is round, whether it is a wavy structure, whether it is rectangular. You should be able to understand when you are moving from caudal to cranial or cranial to caudal, when from right to left or left to right, how the change of structure happens, that you must understand. Okay, now comes the second function of our machines, that is here measure. You can measure. So what are the things we can measure here? We can measure the depth. One thing is depth. From if this is the surface, we can see that how much is the depth. Okay, so for seeing the structure also, so here you can see there is a scale. So this is 5 written, this is 10 written. So here you may think there is a structure. So it must be say around 8 centimeter or 8.5 centimeter. So by this thing, you can measure that what is the depth. Second thing, if there is a circular structure, you can measure the area also, area of the structure, complete area, or even the structure diameter, Okay. So these things are there for measuring. So for measurement purpose, freeze first. You must freeze the picture and then you measure. So this is there one caliper button is there. In some other I mean like different machines, there are different calipers are there. So you can knob can be different. So first freeze and then measure. Okay, for measurement, depth also we can measure, and the area or size we can measure. Okay, so compare with MRI section here. So only thing is that in MRI, here pros and cons, if we think, then any plane, it is the advantage. It is the advantage. As I told, in MRI and CT, it is the sagittal section, coronal section, or axial section you can take. Here, it is any plane because probe is in your hand, and if you just move it from say coronal section or from the sagittal section to 20-degree, then also it is giving another section. Okay, so it is any plane. It is in your hand which plane you will see. And another advantage is it is a dynamic examination. So these two advantages are not given by even MRI. Okay, these are two advantages of ultrasound. But what are the disadvantages? No coronal section. We cannot take a coronal section. Second thing, bony shadow. So bony shadow is I mean, those who are doing ultrasound, for bony shadow is our enemy as well as our friend. How? Enemy because ultrasound wave doesn't pass across the bony shadow, so that is it is becoming an enemy. But it also tells us which area of the bone, or which area your probe is there. Say a patient is very fatty and is hip area, you cannot see from outside that where is the where can be a greater trochanter and where can be neck of the femur, or where can be the head of the femur. Just by putting the ultrasound probe, first you see the bony contour. As soon as you see the bony contour, you can understand that which area I am putting my probe. So bone becomes a friend also and enemy also. So this is one disadvantage. You can say that here in this picture and this picture are of the same area. Here this femur bone, behind femur bone also in MRI I can see, but here there is a big shadow and you cannot see. So this is one thing. Depth part. So it is so in other modalities, no matter what is the depth you can see, but here as the depth increases, picture becomes hazy and you cannot see a very big depth. I mean, so here you can see that 10 centimeter up to 10 centimeters, so you can see, but above that you cannot see. Limited exposure. Okay, so here the whole thigh was being seen, but here only small area. You have to move your probe from right to left or from down to up. I mean, to see the whole area. Okay. Then comes concept of axis. Okay, axis and plane versus axis. So what is the meaning of plane versus axis? Understand that plane, as I told you, axial plane, sagittal plane, coronal plane. Coronal plane is not there in ultrasound, so we will not talk about that. Sagittal plane and axial plane. So here, plane are these two planes. Okay, but axis is related to a structure. Okay, axis is related to a structure. It is not, you cannot say that sagittal plane. So this is a sagittal plane. Just a bit. Okay, so this is a sagittal. What is that? Okay, so this is a sagittal plane and this is a, say, axial plane you are seeing. But you cannot say directly that this sagittal plane is a long axis or it is a, this axial plane is a short axis. You cannot say like that. This is related to the structure you are viewing, you are seeing. Here, the upper one, this is a long axis for the bone, for the phalanges or for the tendons, those who are running like this. Okay, so you are seeing a short, long axis. Okay, this upper one. But this lower one, this is for the bones. It is running like that, but you are cutting like this, cutting like this. So these are short axis for the bones. Okay, but there can be another muscle here which is running like this. Then it will be your probe is more or less long axis for that muscle. Okay, so when you talk about long axis or short axis, think about the structure which you are seeing. Okay, so I think you understood my point. It is about the structure below which you are seeing. Structures orientation can be like this also. Structures orientation can be like this also. In that case, if your probe is here and you are seeing like this is the probe, this is the probe, then this same probe in same orientation will become long axis for upper one and short axis for lower one. Okay. Now let us go for. So how do we see the ultrasound picture? So it is a, as I told you, it is a black and white picture. So how this picture is formed? So first let us compare how we see. So here from sunlight, light is coming to an object. This light is going to our cornea and in our brain, it is being processed. Then we see. Of course, this we know everyone. So let us compare our seeing with transducer. Let us think that it is not light, it is sound. Okay, light is replaced by sound wave. Okay, it is sound wave. And emitter and receiver. Here maybe emitter is sun and receiver is our cornea, but not cornea, actually retina. But then here both the things are probe. Of course, different sections, but these are probe. From probe only sound wave is going coming out. And from this is the probe only where sound wave is again coming back. So this is the emitter, this is the receiver. Okay. Third thing is amount of rays. Amount of rays tells us that it will be what we will see, that is a that will be bright or not, that will be bright or dark. So here also amount of waves will tell us that it will be more white or less white. Less white means more dark. more darker. If there is no wave coming, then it will be jet black. If there is all waves are coming back, then it will be the milky white. Okay, milky white is called hyperechoic. I mean, not milky white, more white means hyperechoic, and less white means hypoechoic, or if it is jet black, then it is anechoic. Anechoic. Understood? So compare with this and understand that this is the sound wave, probe is the emitter and receiver, and picture depends of amount of waves. More wave means more returning waves, means more white, more hyperechoic. CPU and monitor is our work. It is not written, of course. Brain using it is like our brain. It is processing. Okay. So question comes: where does sound wave come from? Answer is electrical energy. So it is not the first time when electrical energy has been changed to sound wave. We have all seen this tape recorder. That is also electrical wave to sound wave. So what is the difference? There has to be some difference because tape recorder is so cheap and ultrasound is so costly. So audible range is 20 hertz to 20,000 hertz. Okay. Whereas USG sound wave is 2 megahertz to approximately 22 megahertz, means 100 times more than our audible range. 20 kilohertz, if you multiply by 100, then it will become 1000 kilohertz. That equals to 2 megahertz. So it is 100 times more than only we start, then only it becomes a ultrasound wave. Okay, 2 megahertz to 22 megahertz. Nowadays, we are getting the probes. Now, so some core physics of that ultrasound wave production by the probe. So, how is the sound wave produced at hardware level? Answer is piezoelectric crystal. So, I mean, we are not going very deep in the physics, but mainly that this crystal is responsible for piezoelectric crystal is responsible for production of sound wave. So remember here, from electric to from through this left side, electric is coming in the probe, and from right side, this is the electric wave is becoming the sound wave. So this electric to sound means reverse piezoelectric effect. Here you have to memorize it simply. Reverse piezoelectric effect means electric to sound. This is a definition. Okay. And what is piezoelectric effect? So sound to electric. Here, as I told you, this probe is emitter also and receiver also. So electric wave becomes sound, again sound becomes electric. So this is reverse piezoelectric effect and piezoelectric effect. Here you see the small picture, the black arrow is the reverse piezoelectric effect. It is the black arrow represents. I mean, the more wave is going, but the small white one is the piezoelectric effect, because again sound wave is coming back and becoming electrical energy. Size of this, why it is difference? Because the amount of energy which is going coming out from the probe to the tissue, that much is not returning. Only small amount is returning. Okay. So mainly what happens at the crystal level, this piezoelectric crystal. So sound wave actually this propagates as compression and rarefaction. There is one main. So if you see the crystal, so when force is applied, this has become a bit rectangular. When there is no force, it has become a bit square. So this movement of the crystal, it produces the sound wave in a simple terms, and this sound wave propagates by compression and rarefaction due to this force and change of shape of the crystals. Okay, what is compression and rarefaction? You can see sometimes this sound waves, they are a bit crowding of waves are there. So this is compression, and this rarefaction is when there is less crowding. Okay. So here, just we remember few sound waves, few characteristics of sound wave. Then we need to know velocity, frequency, amplitude, and wavelength. These four things, they are actually related. They are more or less related. Here, one important thing is frequency in hertz. This is a hardware characteristics. You cannot change if hardware is fixed at when whatever you will fix, that frequency will come. So you cannot change anything here. So this is hardware characteristics. So we will think about the velocity, amplitude, and wavelength. Okay, so here first thing, velocity. First, see velocity. What do we mean by velocity? The ultrasound wave which is passing through the tissue, it has a certain velocity. If it goes through the air, it has certain velocity. If it goes through the air, water, it will have certain velocity. But in the tissue also doesn't mean the same thing. No, there may be muscle, there may be bursa, there may be tendon. So these have some differences in velocity. But for calculation purpose, velocity of sound through soft tissue, all the soft tissue, it has been assumed as constant. That is 1540 meter per second. Okay, so this is the velocity of sound has been taken as a constant. So you see the calculation, d is equal to c by f. D means what? Wavelength in meter, and c means velocity, f means frequency. As I told you that sound wave speed, sound wave velocity in tissue is constant. We are taking it as a constant. But what is the result? Result is frequency and wavelength becomes inversely proportional. That means what? Clinical implication. As you increase the frequency, wavelength becomes smaller. As you decrease the frequency, wavelength becomes higher. Okay. So from this slide, this much only, that frequency and wavelength is inversely proportional. Now, let us why the wavelength is important to us. So understand, wavelength means, say this is a pulse. This is one pulse. One pulse doesn't mean one cycle. It is two cycles here. Okay, it is two cycles here. So in one cycle to another cycle, this is the wavelength. How much distance one cycle can go deep, can proceed, can think about the depth. It is starting from the skin and going inside in the depth. So the depth covered by one cycle depends on the wavelength. So here, if the cycle is more, here you can see if the cycle is more, then distance from the source to go the same distance, there it will be more cycles will be needed. Okay, and here it will be much less cycle will go into a more depth. So you can ask me that what is the where is the problem? If I want to see 10 centimeter depth, then if it is the high frequency or say less wavelength also, it will take 20 cycles to go to the 10 centimeter depth, and it will take say 5 cycles to go to the 10 centimeter depth. What is the problem? Problem is there. So what is the problem? So wavelength is important for distance, as you understood. How it is important? The single thing is wavelength determines the cycle covering the depth. Okay. High frequency means less depth. Okay. So I don't know where I have written. Okay. Okay. I'm just showing you. So here, so as I told you that where is the difference? So you can say that, okay, that say for same distance, more cycle will be there. So here lies the difference is the attenuation. The attenuation amount, say from the first cycle, second cycle becomes 10% smaller. Third cycle becomes another 10% smaller. Fourth cycle becomes another 10% smaller. So what happens? In here, more cycles means for the same depth, ultimately the 10th cycle is not even not even 10% remaining. It is 90% is attenuated. It has become smaller. But when the wavelength is more, the same distance has been covered by 3 cycles only. So attenuation will be say only 30%. 70% wave is still there. Okay, 70% cycle. So that is the reason. That is the attenuation is the reason that more number of cycle cannot compensate the wavelength effect. Okay, so wavelength is necessary for the depth. So for clinical implementation, clinical use, you remember high frequency probe goes to less depth, and low frequency probes, low frequency is used for high depth for ultrasound. Here, so high frequency means less depth. So here, see, for deep abdomen obstetric gynecological imaging, usually we use 2.5, 3.5, 3 hertz nearly, megahertz nearly. But superficial structures, we need to see by 15 megahertz. Okay. So there are multiple types of probes. Okay, there are multiple types, but then for our, as a pain physician, for musculoskeletal ultrasound, we are more interested in linear probe and curvilinear probe. In linear probe, of course, sometimes bandwidth is written and sometimes it is not. Nowadays, we are getting a broadband probes which have a big range from say 3 hertz to 17 hertz like that. And so this is a hockey stick probe, this is linear probe, this is your curvilinear probe. So where from this nerve name comes from the footprint. This is a curvilinear footprint, so it is a curvilinear probe. This is a linear footprint, so this is a linear probe. And it is looks like hockey stick, so this is hockey stick probe, but this is also a linear probe only. And so one part is footprint, and this is the body part, and this is handle part. So footprint, body, handle, these are just parts of the probe. So USG probes, why we need all different types of probe? So it is for field of view, the crystals which are arranged in a different way. So you can see in a curvilinear array probe, there are these area of visualization becomes much higher, okay, much higher. And this makes a cone. This makes a cone type of area, conical shaped. This one image you can see, and here it is a rectangular shape image. Okay, so this much only. The size of your probe and size of your picture is same, but here it is much increased. So higher frequency probes have better image resolution, spatial resolution, whilst sacrificing the depth of penetration. So as we have already understood that high frequency means less depth. But then what is the use of high frequency? If it doesn't go to that depth, why should I use that? Because of increased resolution. It shows the picture much clearly. Okay. So this was, I was saying that we all have learned about the story of this tortoise and rabbit. So you can say that, okay, rabbit goes faster and it goes smaller. Say these two types of high frequency or low frequency, but the same depth can be crossed by different number of cycles, but it doesn't happen because of the attenuation purpose. Because at the same distance, if it is a high frequency wave, it doesn't produce any picture anymore, because the sound wave is so much attenuated at this depth, it doesn't reflect any sound wave to the receiver. In a low frequency probe where wavelength is higher, it is not that much attenuated. It is also attenuated, but not that much. So here from this slide, the attenuation is the main point. So what is attenuation? The amplitude and intensity of ultrasound wave decreases as they travel through tissue, a phenomenon known as attenuation. So this whole length is amplitude. So this amplitude also decreases, and in amplitude and intensity, the same thing. So amplitude decreases. So this is called attenuation. Here, attenuation is result of several features of sound wave interaction with tissue and tissue boundaries. So attenuation occurred, we have understood. Why attenuation occurs? So that is called reflection, refraction, or scatter, divergence, diffraction. These are same. Then absorption. So what are those things? So like sound, any light wave only, you compare with light. So when the sound wave is coming to the tissue, either it can reflect, okay, or it can refract also. Here, media one, media two means two different types of tissue. If there is a two muscle layer, then also two different type of tissue, or say muscle and another ligament is there, so that is also different type of tissue. So, or there is a fluid level above the and above that there is a muscle, so that is also different types of tissue. So in these areas, mainly the reflection occurs. So here in this area, so one thing is reflection. Some sound wave is reflected, and you see the reflected in a different direction. It is not going to the probe anymore. And another one is refraction. So refraction is also going to another direction, okay, but to the second media. Reflection means it is reflected to the same media, from the previous medium, and it is going to the second medium but in a different direction. And attenuation, so ultimately result is attenuation. What is the if some wave goes out in this way, then result is attenuation. And we are actually concerned about the sound wave which is directly coming in a straight way, because this is the wave which will reflect to the probe. So whatever amount is reflecting to the probe, that will make the picture, that will give you the main image, and others are the cause of attenuation. So here these reflector and refractor, so these media, the interface between two types of tissue mainly becomes the reflector and refractor. So this is scattering or divergence. So what it happens when it is something is reflecting, it is like causing one wave coming and it's reflecting and causing one wave. If it causes multiple waves in multiple directions, if the surface is too much too much irregular, and the incident sound wave is going towards all direction, when it is called scatter. So this is also a ultimately way how attenuation occurs. So reflector, here we have understood reflector, refractor, and acoustic interface. So these are the mainly this reflecting surface, this media 1 and media 2, these are called acoustic interface. So tissue 1, tissue 2, tissue 3, all the different layers, they become an interface. From here the sound wave again is reflected, okay. Now don't think in a muscle the one muscle above and one muscle below, so in between is the only interface. No, it in between also it is the major interface, but inside the muscles also every fiber between them there is a interface, and that's why some amount of sound wave is reflected, and we can see it is not that we see the perimeter of the muscle, we see inside the muscle also the perimysium. So they also act as an interface. And every time you see that it is going down here, the due to attenuation, first see the black one. So black one is the emitted ultrasound wave. So it is every time one interface it is crossing, it is becoming smaller. So it is the due to attenuation, and then it comes back, and the white one is bigger. You can see white one is bigger. How come the white one is bigger? Because it is not that the from the distance, from the maximum distance what is returning, that is actually not becoming bigger, that is adding up with the earlier one. That's why it is becoming bigger. Here it is compared with this much, and it is compared with this much, this black to this white, this black to this white, and this black to this white. So ultimately, due to attenuation, the ultrasound wave goes down. Oh, another phenomena is absorption. So there can be some structure where nothing is reflected. So it can cause completely there is nothing reflected. So what will happen? Picture will become jet black, and the whole sound wave is absorbed. So what are those tissues? You can say not tissues. So what are the substances which causes like this type of absorption? Water, or say blood, liquid blood. So they cause, when we see artery or say effusion, when we are seeing the effusion, all sound waves are absorbed and then nothing is being returned. So that part becomes completely anechoic. Okay. In ultrasound, absorption is the reduction in intensity of the sound wave as it passes through tissue. Most of the energy lost it in the form of heat. And so heat is formed. Of course, energy cannot be destroyed or created. It is always changed from one to another. So best absorbing tissues. So here also these also they do not become anechoic, but they also absorb quite a lot. So they give hypoechoic picture. So ligament, tendons, facet, joint, capsule, etc. Okay. So another thing, summary of attenuation. So understood: reflection, refraction, scattering, and absorption. Next question: what is the amount of reflection? Is the amount of reflection same in all tissues? So here you see. Then another question comes. Reflection, as I told you, that say 100, I give a simple marking to the incident ultrasound wave which has come from the ultrasound probe. Say it is 100. So the next interface, next layer, when it will enter, if the 70 passes, then only 30 has the option to come back as a reflection. Okay, if I don't think about the other attenuation things, other attenuation factors. So it is the density, or it is the density of that medium that is causing that is causing the, or say that is that resistance of that medium is indirectly fixing the amount which is returned. Okay, so impedance means resistance. Impedance means resistance. So here you can see full reflection at air gaps. There is some air gap, and the sound wave came up to the air gap. Air gap means what? Say inside the muscle you have due to something you have made one injection of some air. So by ultrasound, if you see at this level, all the sound waves will get reflected, and you will see. So what will happen if everything is reflected? You will see this area as bright white, very hyperechoic, and you cannot see anything beyond that. So this happens with the bony margins also. So the impedance of bone is so high that all the sound waves are reflected. Okay, so here again the impedance is less. Many sound waves are propagated. Only few sound waves are going back to the probe, and you can see a hypoechoic picture. Okay, if nothing goes, then it will be anechoic picture. So here you see resistance. As I told you, resistance or impedance of the second medium will decide that how much the sound wave, incident sound will get reflected. So you see, air has the if this is of course due to different reason, but then bone is 7.8, so it is so much of impedance, and muscles 1.7, fat 1.4. So this is the areas due to the difference in their resistance. This is due to the resistance. So for bone resistance, nothing can pass and everything can come back like that. In fat muscle, there is something can pass and some other will get reflected. Okay. So these are called acoustic impedance for different tissues. Okay, these are different acoustic impedances, and as I told you, acoustic impedance depends on density of the tissue and velocity of the sound. Both the things are important for acoustic impedance. Next, go to the application part. So this much of physics, you can say the background physics is it's all right. Let us go to the application part. So all interface has a different amount of reflection. This much we have understood. How and why? That is due to the impedance of the next tissue layer. Okay. So no reflection means completely black picture. Black and white picture we have talked about. So if there is no reflection, that is completely black. If 100% reflection, that is milky white. After how this color comes after it has been processed by the CPU. So amount of reflected wave that will give the color. So this is a digital calculation. We don't need to understand that much. So if there is more and more your reflected wave, then it will be hyperechoic. Anechoic, hypoechoic, hyperechoic. So till now, let us just recapitulate what we have learned. Introduction part, we have understood that cross-sectional image, one is rectangular and one is cone-shaped. Okay, no, first thing is in cross-sectional image means by probe we are seeing the cross-sectional image in a different way. So rectangular wave is seen by the linear probe, rectangular picture, and cone-shaped picture is seen by curvilinear probe. We are seeing a short axis or long axis which is related to the structure. You cannot fix it in a fixed way. You can say that, okay, I am putting the probe like this, it is short axis to everything. Nothing like that. So short axis to long axis depends on the structure which you are viewing. Then we have understood the types of probe and parts of the probe. Footprint is most important. Then comes body and handle. And aspect marker is important to understand which is right and left. One midline mark is there sometimes in the probe, but many probes do not have. Why this midline mark is given? Midline mark is there in the probe also, on the screen also sometimes, that just to locate that where you are seeing. I mean the mid part of the screen is on the structure or not, by putting the midline on the probe on that structure. So that mark sometimes is there, sometimes not. Machine, as I told you, that depth, we can see the depth in the machine, and by caliper we can measure a structure's area also, and how much depth that structure is, that also we can measure. This a machine has multiple other things. This much we have read till now. Then physics part, probe is both emitter and receiver. Piezoelectric effect is the main reason of ultrasound wave. Characteristics of sound wave, what are the things we understood? Velocity, frequency, amplitude, wavelength. And the main importance is that high frequency means less depth but more resolution. So opposite is true also. Less frequency means more depth but less resolution. Causes of attenuation, we have understood why the attenuation occurs: reflection, refraction, so absorption, all these things. And reflection, why it occurs? Acoustic interface and acoustic impedance. Okay, and black and white picture, why? Because it is the, if it can become no reflection, so it is anechoic, no reflected wave to the probe again, and there can be some amount partial wave is reflected, so that will be hypoechoic, and if everything is reflected, that will be hyperechoic. Now let us understand some other machine mechanisms, machine controls. Okay, so if this is a black and white TV, earlier days we had black and white TV. So we can say somehow that gain is brightness. When there is a gain button, if we increase the gain button, it will become brighter. Okay, whitened. Okay, so gain is a uniform amplification of the ultrasound signal that is returned. Okay, so what happens actually? So it is like from the it is like brightness only, the same amount of reflected wave. The CPU is, what it is doing, it is augmenting the wave. Say it is I give a number of 5 wave, reflected wave, so machine is just multiplying into 2, so it will become more brighter, the whole picture will become brighter. So that is gain. So examples of gain adjustment here, it is hypoechoic. Everything is become hypoechoic structure. Low gain setting. This is low gain setting, and this is high gain setting, and this is optimal gain setting. So actually, gain should be optimal. Otherwise, structure is not seen very clearly. Okay. So this is low gain, this is high gain, and this is optimal gain. Gain main importance is to it helps in differentiating the structures, differentiating the different structures. Okay. Now, another function is TGC. TGC. Another ultrasound machine function is TGC. What is the TGC? So, as you understand, then that our ultrasound is much costlier than a black and white TV. Then function also, it has some additional function. So earlier I told that it is like a brightness button. You have increased the gain, whole picture is become white. But if you want to increase the whiteness or brightness at some point, some level, then you need this TGC function. TGC means time gain compensation. What it does, it will select the whole screen. No, it will not select the whole screen, and it will select certain amount area of screen which you want, and that part signal will be augmented. So here you see these buttons right sided, upper buttons are I have made right sided, so this picture has become, the upper part of the picture has become bright, and this is in the middle, so it is like that. And if it is the opposite, then lower part of up will become brighter. It is the same area, but the area of brightness you can change. So what is the clinical use? I will make bright of that area which is of my interest, which I want to see more clearly. So brightness of that area I will adjust. So that is the TGC, time gain compensation. Another picture function is dynamic range. What is dynamic range? I again just show you. Say I give this picture. Say this picture has a dynamic range of this. Okay, this much. The most say one anechoic structure like one effusion will become this much black, and if there is a periosteum or say periosteal or ear reflection, this should become this much white. So this becomes the total dynamic range. Okay, I can make the dynamic range smaller, so it will become like this. So what will happen if it is a completely anechoic structure? It will become this much black, up to this much. If it is completely something reflecting 100%, then it will become this much white only. So this is the dynamic range. So this also you can change, but in clinical practice we do not use this, but you can usually the software engineers, when they come, they use this thing to to make the picture more clear. But in clinical practice, we do not need this that much. Another thing is focusing. So this is also an electronic means to narrow down the width of the beam at some depth. So nowadays there are machines which have automatic focus. You don't need to focus, like our mobile has become automatic focus now. So here also, but some machines have focus. My machine also have focus. So if I want at some depth, wherever is the structure, my structure of interest, there I will. This is the focus probe. I mean focus A point. So see, this symbol, so I can make it down, make it go up. So the depth at which I want it should come. So there it is a electronic means to narrow the width of the beam, ultrasound beam. That part will become much clearer. Okay, we can see that thing much clearer. What you meant. Okay, anyway, so next one. Now comes resolution. So all the things what we have done is for seeing a structure more clearly. Seeing a structure more clearly, all the things we have done. We have adjusted focus, we have adjusted depth, we have adjusted even dynamic range is also possible. PGC we have adjusted. So ultimately, what is the result? Result is resolution. So there are multiple types of resolution, but here for our purpose, spatial resolution may be two types, axial and lateral. What is axial resolution? In the same plane, the upper, you can see, in the same plane, you can see, this is the plane, if you can think, then in the same plane, if you can identify two dots in a two different as a two different structure, that is good resolution. If all mixes up together and it becomes like this, then it is poor resolution. But the another spatial resolution is lateral resolution. So in laterally also two structures should be separate, completely separate. So this is called resolution. Depth and zoom. So that already I have told that depth is always there in the right side of your screen. Here you can see 5 centimeter, 10 centimeter. So whatever required, your structure of interest should be in the middle third of the screen. That is much better. Okay, to see a structure in a better way. So that is by adjusting depth, you can do that. Okay. And zoom also sometimes we use. Here you can see that all this part is zoomed, so it looks like this. Okay. So first step, step by step, if I go, first switch on the machine, choose the probe. For you, when you have planned that I will go for a ultrasound of some structure, choose the probe, position the patient. Then position means which position is necessary to see that area of the body. Mind the aspect marker before you touch the probe on the patient's body. First see that which side is aspect marker. Then apply gel. Why we should give we should apply gel? So that there is no air in between and there is no, I mean, like so otherwise artifact will come. So there should not be air in between when the sound wave is going inside the tissue. Decide axis and start scanning. So whichever structure you think first, that what can be the orientation of that structure. So first I mean, then you think about the axis. Either you are seeing in short axis or long axis, then start scaling. Then you will adjust the gain, depth, focus, etc. as per the need. Now there are some artifacts, very important artifacts. So when we are seeing, there is one artifact called anisotropy. So here also just understand it clearly. Say this is the skin. Okay. Under that there is one this type of parallel structure, say rectangular structure or what is there, whatever there. So there is one parallel structure. So something will, all the rays will get reflected like this. Okay. So when the image you will see, you will also see a same type of hyperechoic or hypoechoic, whatever, a same type of echo signal in the whole length, and you will see. So this part
I
will
book
give.
have a mic need. Ready? Use it.
Oh, somebody is talking. Please do not talk. Mute. Okay, so this part, this thing will represented by this line. Okay, so that is normally there is no anisotropy, there is no artifact. This is normal. What we want to see, but think about another condition. Another condition when there is a this is skin and the lower structure is a bit curved, a bit curved. Okay, so some part will get reflected, and this part will make this part. Okay, but what will happen to this side? This will not get reflected, this will go in this way, and it will not go to the probe. So ultimately this side will not be seen, this side will not be seen. So normal structure is like this, but you will see only this much, and this side some darkness, this side some darkness. So that is called anisotropy. Understood? I will show you. So on the machine, then you will understand. Okay. So then what is the what you can do to I mean overcome this problem? So you understand, if I move my proof like this, say here this is the structure. Okay, and we are seeing from here. Okay, so if I move the probe like this and my probe becomes like this, then I will see this much structure. When I am in this position number 1, I was seeing this part. When I'm in position 2, I am seeing this part, and then I will move in this way, and then I will see the position number 3, this area. Okay, this is anisotropy artifact. So okay, so as I told you, to overcome the anisotropy, one is heel toe maneuver. So this is called heel toe maneuver. What I have done here just now. So this is heel toe maneuver. So this one just I have shown you. So this is to overcome the anisotropy of some area, because when this area you will see, then other area which you were seeing will become anisotropic, because everything cannot become parallel together. Okay. So but you have to see the whole area one after another. So this is heel toe maneuver. Then this is also another maneuver. This is called fanning. This is fanning. This is also anisotropy. Why this is also for anisotropy? Because as I told you that this is a curved thing, this is a straight. But this curvedness can be in this way also, in this way. Okay, if I can show you the direction, understand the direction. This is 90° to this one. Okay, the 90° to this one. Both these are 90°. Okay, I want to show. So here, as I told you, your probe will come like this or come like this. Here, what will happen? So this will come in this way or in this way. Okay. So both the movements, this movement and this movement, they are 90° to each other. So this is heel toe movement. This is fanning. Okay. Other movements are there. This is very easy to understand. Sliding, just along the long axis of the probe, it is sliding. Sweeping along the short axis of the probe. These are just for remembering. Otherwise, nobody remembers them. While doing ultrasound, everyone can do what is needed. If you understand the concept, you will understand. So sliding, sweeping, rotating. Rotating means from short axis to long axis. When you are seeing a structure, you rotate this, rotating. Heel toe maneuver. Already I have told you. This is heel toe maneuver. Another is, so fanning also I have told you. Fanning also I have told you. Fishtailing. Fishtailing is what? Fishtailing is, say, I am seeing one structure like this. Okay. Now, here there is a bone, here there is a bone, and my probe is like that. Now, second probe position is one part is there, but another part is moved. So this is called fistelli. I will show you. Okay, gel standoff. Gel standoff, why it happens? Uh, this is my probe, but this is the skin, but below the bone part, which so this is the probe and bone is like that. Okay, so whatever you do, this part of the probe will not touch over the skin. So what you can do, you can fill the area with completely gel. So you can do like this. So you can put a gel like this. So whatever it will be like this then. Okay, so this part will be filled with gel, and so there is no air gap. So this is called gel standoff. Compression is nothing. I mean, you can compress and see whether it is artery or vein. Two vessels look like same, but vein is compressed, artery is not compressed. Artery is pulsatile instead. So you can know that whether you are pressing an artery or vein. Okay. Okay. Here, some important thing is Doppler technology. Till now, ultrasound probe we have compared with eyes. Now I am comparing it with ears. So think that this ultrasound probe can hear the returning sound wave. Okay, it is not seeing, it is hearing the returning sound. So it can understand which sound wave is coming towards it and which sound wave is not coming towards it or going away from it, and it can process accordingly. If sound wave is coming here, see one train is coming and this train is going, and when you are standing on the platform, so sound wave which is coming towards you, it becomes gradually sharper, and when it is going away, then it also goes down. Sound also decreases. So here also you think that this is an ear, and the returning sound wave, the intensity decreases if the sound wave reflected from the RBC is decreased. Then it understands that it is the vessel which is going away, and if it comes more, the sound wave increases, then it understands the RBCs are coming towards it. Then it is a whichever vessel the flow is coming towards it. So that is called Doppler technology. And always remember that if it is insolation angle is 90 degree, there is no flow, it will not show any color. So it has to be a bit tilted. So logically, if it is really 90 degree here, so it is these RBCs are coming or going. You say some RBC is going like this. Okay, this. So if someone considers this part of RBC, it will say it is going away, and if someone considers this part of RBC, it will say that it is coming towards the probe. So you cannot come to a conclusion. But if I make the probe a bit like this, tilted, then this part will not be taken care of. Only this part is taken care of. Then you know that RBCs are coming towards the probe. So this is ultimately processing that CPU processing that red color is given when the sound wave is going towards the probe, and blue is given when it is going away from the probe. This color setting actually is in engineer's hand. They can change it also, but usually it is like that. So this is called color Doppler, to understand which one is artery and which one is vein, and in different areas where there is needed. As a pain physician, truly speaking, we do not want to know that we do not want much of do not have much of color Doppler use. More use is power Doppler. What power Doppler says, what we do with power Doppler? Power Doppler says that whether there is a vessel or not. And be it artery or vein, no question of direction, whether there is a vessel or not, or artery or vein, whatever. So vascular structure is there or not, that is known by power Doppler. So if you want to see a vascular area, more vascularity, we can use of power Doppler. There are some Doppler artifact like random noise. If there is too much gain, you have increased. So there will be, I mean, this type of color comes which doesn't mean anything. So it is not vascularity because the same color doesn't appear in the same area again. So that is called random noise. Mirror artifact is also another thing. So here gain should be decreased. Gain should be decreased. Mirror artifact, for mirror artifact also gain should be decreased if you are using Doppler and this type of thing comes. Tissues under USG. So skin, for seeing skin ultrasound, transducer of more than 13 megahertz are necessary. But if you want to really see the skin only, but with our this one, our probe, you will see skin as a hyperechoic structure. This part is skin. This part. So this part is skin. Okay, this part is skin. Then comes subcutaneous fat. So what is the subcutaneous fat? If you see, so subcutaneous fat is this part, hypoechoic, this part. Hypoechoic subcutaneous fat with thin horizontal hyperechoic stria. So you can understand these are thin horizontal hyperechoic stria, inside being the connective tissue fibers. So these are connective tissue fibers. Okay. Remember, lipomas are hyperechoic compared to the surrounding hypoechoic fat. Means both are fat, but when it becomes a lipoma, it becomes a bit hyperechoic. Here, one more important thing. There is nothing called absolute hyperechoic or hypoechoic. It is related to the surrounding. Like that's why as I'm telling that lipoma is also fat, but it is called hyperechoic. Why? Because the surrounding fat is even darker. The lipoma is a bit more white, and this lipoma, if we consider compare with a tendon, it will become hypoechoic. Then tendon or say some periosteum that are much more hyperechoic than that. So then it is not absolute, it is relative. Okay. Muscle. So here you can see two type of muscle fibers. You all know that muscle has this endomysium, perimysium, epimysium. So these fibers, if this from this fiber, we can understand that this is a long axis. This is a long axis. Okay. Just a minute. Okay, so this is a long axis, these fibers. Okay, long axis of the muscle, long axis of the muscle. So this is a longitudinal wave image. So hypoechoic with parallel and oblique echoic fibers corresponding to the endomysium, perimysium, epimysium. So these are fibers, so fiber structure. And in transverse wave, so this is called starry night appearance. That these fibers only, if we cut like this, then these become spots. These become spots. So this is a typical picture of muscle. Tissues, tendon. So tendon is hyperechoic fibrillar type. Okay, tendon is always hyperechoic fibrillar type. Hyperechoic fibrillar type. Hyperechoic fibrillar type. Okay. Then comes ligaments. So ligaments and tendon are many times it is same only. Only thing is that ligaments similar only. But thing is that ligament goes from bone to bone and tendon goes from bone to muscle. So ligaments. Then comes tissues. So which tissue? It is nerve. So it is the nerves. So here what we are showing you, nerves has a characteristic appearance that is called honeycomb appearance. So you can see this is the honeycomb appearance. Okay, this is the honeycomb appearance. So what happens? Hypoechoic fascicles separated by hyperechoic endoneurium, perineurium, epineurium. So hyperechoic are not nerve fibers. These are the this endoneurium, epineurium, or perineurium. And this is the honeycomb appearance. This is the honeycomb appearance. So this one I will show you. You just try to remember cartilage. Cartilage is again anechoic structure. Okay, these are the cartilage. So complete thing is absorbed, and I mean it is, there is all the tissues. There is no reflection from the tissue here. So that's why it is the completely, there is no resistance, no impedance. So that's why it is completely anechoic. Nerves, cartilage. Okay. Bursa remains a potential space. If there is no fluid, you cannot see. Only a small area. Sometimes in normal person also there is some fluid. So then in that case only we can see. So this is under the Achilles tendon. This is the Achilles tendon. So here you can see sometimes some fluid in the bursa. Vessels, as I said you, this is the anechoic structure, anechoic round structure. Just by pressure compression method, you can understand that whether it is a artery or vein. And of course, you will see pulsatile or not. So what we did not talk about, different modes of machine and side effects of ultrasound. We are always using only one mode. We are saying that this is the B mode. Okay. Movements of the probe. Okay, I will show it. So, okay. So any confusion you have, tell me. Otherwise, I will go for
Sir,
demonstration.
hello, sir.
Yeah, yeah, tell me.
Sir, I have one question, sir.
Yeah, tell me.
Sir, I think, sir, during adjustment of the gain,
Hmm.
is there any reference or it's only subjective, sir, about the resolution, sir, for maintaining the resolution?
No, it is subjective. It is subjective. Yes, yes.
Okay.
It is
Okay, sir.
completely subjective. There is no fixed protocol or fixed anything like that.
Okay, sir. Thank you, sir.
Okay. So, can you hear me?
Yeah.
Okay. Spotlight for everyone. Okay. Okay. So, see, so few things. So this is a ultrasound machine. Just a minute. Oh, okay. This is the problem. Anyway, so this is the ultrasound machine. So you can see different knobs here. You can see different knobs here. So one thing is important here. I don't know whether I can show. Okay. So I think you can see now. So first, what we do when ultrasound machine is switched on, then in general we search the probe. We select the probe. So here I am selecting the probe. Okay. Then there are some presets. There are some presets. These presets are made by me only. Sometimes made by company with the company people. We so I am using one preset. So this is a MSK preset. Okay. Then there are some so I can see that okay, this probe this ultrasound screen has come. So this is a rectangular screen. That means I have selected the linear probe. I have selected the linear probe. That's why the rectangular screen has come. So here actually what happens, there are some other. So this is a freeze button. This is a freeze button. If I if I freeze it, then actually I can measure. I by caliper button. So there is a caliper button. So these things are there. So this is a caliper button. Okay, this is a caliper button. You can see that. Okay, already you can see, no? So I keep my this one here only. Okay, so this is the caliper button. Here you can, if I want to say I want to see some structure at say 2 centimeter depth, then I can measure from here. I can measure from here. So say from till here. So I see it is the 19 millimeter depth. Okay, so here it is the in the upper part it is written it is the 19 millimeter depth. So through by which we can see the depth also, and then we can see the area also. There is another method of seeing the area. I can show you here also. So these are the areas like this. Okay, so this is showing you a area also. So this is a measurement button. Okay, so what are the other buttons here? Okay, so other buttons you see, there is a depth button. This button is depth button. Whether it is okay, depth button. So here you can see the how much depth is selected. So I can, so here now you can see it is the 4 centimeter depth is selected. I can increase the depth or I can decrease the depth. I can increase the depth to 5 centimeter, 6 centimeter, like that. Now it is nearly 7, 6, 7, 8 centimeter. I can decrease the depth also. So it is the 2 centimeter depth now. Okay, so here you can see just beside one. Okay, this is not coming in the screen. So here I just show you just beside the screen, beside the one, what is written there? One, there is a red mark. Okay, so this red mark is nothing but focus. This red mark is nothing but focus. I can decrease the focus, I can increase the focus. So see, I can take it up, I can take make it down. So this is by focus button. Here also there is another button. So this is called focus. This is called focus button. Okay, this is focus button. So I can increase or decrease the focus. So this is to whatever my structure of interest that I can make it, that it is the I will take the focus at that depth. Okay, these are TGC. So when I will, so here you can see the screen. If I decrease the TGC here, so say I make all the TGCs in the left side. So now the screen has become completely black. So if I want the deeper screen to be more hyper-echoic, more bright, then TGC, with TGC I can do that. I can do at every level differently. I can do at every level differently. Okay, so this is the use of TGC. But then if I want to increase the overall brightness, then I can do like this. So if I decrease the overall brightness, it becomes completely black and it becomes completely hyper-echoic or bright. This is not hyper-echoic, this is bright, more bright. Okay. Then, so let us start the other things. It's okay. এটা কাজ করুন, কি শুয়ে যা। Okay. 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 So let us see some structures here. First, I will show you the muscle and tendon. So here you can see that I know that in this area, in this area, there is quadriceps tendon. Okay, so if I hold here, you can see this is a linear probe. This is a linear probe. Okay. Okay, this is a linear probe. How we know? Because this is the footprint. Footprint is straight. So this is a linear probe, and otherwise also while I have switched it on, it is giving a rectangular view. Okay, here of course this is the aspect marker. This is the aspect marker. What it says me? It says that this end of the probe is the left side of the screen. This end is the left side, and midline, sometimes in some probe the midline mark is also there, but in my probe it is not there. The midline mark is not there. And here also the frequency range is not written. Frequency I can change in the screen, the frequency. So here let me show you. So here what I am doing, I am putting the aspect marker in the cranial side. So left side is cranial side. So what I am seeing here, just a minute. I will increase the depth now, because this is a very deep area and I have to, at least it should be 4 centimeter depth. Otherwise I will not be able to see anything. So what we are seeing now, above you can see the starry night appearance. So this is nothing but the muscles. So this is nothing but the muscles. Just I show you. So this is the okay. So this is the starry night appearance of muscle. I think you can see clearly. This is the starry night appearance. So this is the muscle, how it looks like. Okay. And what is this thing? This is the periosteum of bone. This is bony margin or periosteum. Okay. I will show you now tendon. Will take a bit less depth otherwise. So this is the tendon area. So you can see this is the tendon. This is a fibrillar structure. but you can see that this has become a bit darker. So here is the use of my gain. I will increase the gain a bit to increase the picture quality. You can understand the quality will increase. So I show you now again. Here I can decrease the depth. There is not needed to see this much of deep. So this is the depth I have decreased. Okay, and I can increase the focus. If I want to see the this tendon, I will take the this is you are not being able to see in the screen, but I have taken the focus on the at the tendon level. Okay, so you can see the screen, I mean very nice fibrillar structure. Okay, very nice fibrillar structure you can see. So this is nothing but tendon. Okay, so this fibrillar structure is nothing but tendon. Okay. Okay. So let me show you one bursa here. So just see this area only. As I told you, only in some areas of bursa there is fluid in a normal individual. So this is the deep infrapatellar bursa. This area, it is anechoic. Some amount of fluid is there. See again. So this is the whole fibrillar structure. You can see big fibrillar structure. So if I, in this area, just in the lower end, there is some fluid. This is some fluid here. So this is the infrapatellar bursa. This small amount of bursa, small amount of fluid is normal. Okay. So this is the bursal fluid. Otherwise, in everywhere where there is no fluid, you cannot see the bursa. So this structure I have shown. Now the important structure is actually nerve. I need to show you the nerve. Heart. Okay, so just see the nerve. Okay, so I show you the nerve. So here, oh, okay, anyway. That's it. Okay, so you can see the area. So here also, the aspect marker, this is the aspect marker. So I know the medial side, this side, medial side is left side. Okay, I put my probe like this. So here, just you see the middle of the screen there. Can you see a honeycomb appearance there in the just in the middle of the screen? If I decrease the depth a bit more, okay. Okay, so this just in the middle of the screen. So this is the nerve. This is the nerve. Okay, this is the nerve. Now I can do. You have understood that what is the meaning of sweeping. So if I do this movement of sweeping, then I am tracing the nerve to the midline, to the mid forearm. I am saying mid forearm. So this movement is called sweeping. Okay, you can see the nerve. So this is the nerve. I have kept in the midline an arrow. An arrow is over that. So this is called honeycomb appearance. The movement which I am doing, that what we call as sweeping. Okay. Okay. Then comes side to side movement. Okay. So side to side movement, of course, you don't have to I mean, there is nothing to nothing big in this. So side to side movement, this is the, yeah, I can do like this. I can go to see another end. I can go to this end also. Okay, so this is okay. So yeah, next movement is rotation. Rotation, as I told you, so this is the nerve. Okay, so I am seeing in the short axis. This is the short axis view. I am seeing in the short axis. Now I want to see this nerve only in the long axis. So I will go for a rotation. Here what I am doing, I have to have a idea of my aspect marker. So my aspect marker is now going in the proximal side. So this is the nerve. This black one is the nerve, and left side of the screen is the proximal one, proximal side. Okay, proximal side. So this is called rotation. I have rotated from the short axis view to long axis view. Okay, from the short axis to long axis view. This is called rotation. So any more thing? Okay, now another movement is called your anisotropy and heel toe maneuver. So anisotropy and heel toe maneuver. So just you see, ঘুরে যায় একটু না এরকম এরকম বাস that's it. So just a minute. So what happens is, say, anisotropy and heel toe maneuver. So here, say here there is a subscapularis tendon. Okay, subscapularis tendon. Here what happens? This tendon here the skin is a straight line. Okay, skin is a straight line, but below the tendon is not straight. Tendon is like this. Tendon is like this. It is a rotated thing. Tendon is like this. Tendon is like rotating. It is going down. Then what I have to do, if I need to see, just I am showing you this area. Depth I am increasing, otherwise you will not be able to see. So I am just, I have to increase the gain also. Okay, so here left side of the skin is the lateral side. Okay, so here you see what happens. Okay, here if I hold like this, okay, so here what happens, this part is white, this is a tendon. Okay, this is white, hyperechoic, but this part is black. It is not due to actually there is no degeneration or any problem. It is due to the, you see the tendon is curved. It is going down. Okay, and this skin is straight, or our probe is in this way horizontally placed. So some reflected waves, these waves are going to the probe, but the waves which are coming to this area, they are not reaching to the probe. That's why we are not being able to see this area. Now if I just tilt I do a heel toe maneuver, I tilt this area, then I will see this area also hyperechoic, but then again this area will become hypoechoic. So you cannot see the whole area together, but one by one. Okay, so I show you the heel toe maneuver, and you will see that this area also will become hyperechoic. So this is the thing. This is the area. Now if I do like this, you will see. Okay, so yeah, so you can see so you can see that now the whole area is white, but if I put like this, then right side is becoming black. and I can make the black part again white. So this is called heel toe maneuver. This is called heel toe maneuver. Okay, so this is called heel toe maneuver. Okay, so I am making my probe parallel to the tissue of concern. So this is heel toe maneuver. Okay, artery and vein, there is hardly any big thing. So there is only, okay, so artery and vein here also, though I want to see the right side and left side, so left side is lateral side here. So you can see there are vessels, it is clearly seen actually. So these areas, okay, I decrease the depth, so these areas, if you give compression, it is getting compressed, but one is getting compressed, one is not. I'm giving so much pressure, but the lateral another side one, this one is not compressed, and the another one is compressed. So I know one is vein and one is artery, and if I keep it I mean like my probe in a steady manner, I will be able to see the pulsation also. So this is the artery and vein. Okay, you can apply color also. So here, as I told you, okay, no. Now this is part of the CFM. Okay, so color one also I can just put. So you can see one is red, one is blue. That means what? This is the I mean red one is means artery. This fluid, this flow is coming towards the probe, and blue is going away from the probe. And what I am seeing is due to increased gain. This is a artifact of Doppler. Okay, if I decrease the gain, it will gradually decrease. Now it has decreased a bit. So this is the I mean like color Doppler. So anything else I have not shown you? Okay, just another thing, anisotropy, as I told you, this heel toe maneuver I showed you, but another is your gliding. So that is also done for anisotropy only. So as I told you, here you have seen the structure was in this way bent, but there can be in this way also, it can be bent. Okay, so what will happen then you just see that there is a structure here which is black. Okay, okay, just a minute. There is a black structure. I can make it white and then again black. So I'm making I'm keeping it in the midline so that you can see, and I can make it black, white, black, white. Can you see? So this is also nothing but due to anisotropy, and this anisotropy because the structure is like this. So if I move in this way, then only you can see that sometimes the beams, the ultrasound beam is reflected to the probe, and sometimes is not reflected to the probe. Okay. So I think I have completed basics of ultrasound. Anything else? Hey, you can hear me or not? Hello?
Yes, sir, we can hear you.
Okay.
Audible.
Yeah. So any question, please tell me.
Sir, I want to ask about the markers, sir, about the position of the marker, sir.
About the markers position, markers you are saying.
Yes, sir. Aspect marker, sir.
So aspect marker is there, no? I mean, aspect markers. It is this is this is the aspect marker. This is the aspect marker in my probe, my machine's probe. This is the aspect marker, and
Okay.
simply this side will be in the left side of the screen. You can see there something is written S. In the left side of the uppermost corner there is S written. This S means this side. Okay. Now it is up to you that where you want to keep this side. I can keep this side in medial side of the patient. I can put in the lateral side of the patient or in the cranial side of the patient. This is up to me. But then, as I told you, the picture which I will see. So these are all axial cross sections. Okay, whatever way you are seeing it, these are all cross sections. And when you know that whether you are seeing from medial to lateral or lateral to medial or cranial to caudal, you can make a 3D reconstruction in your brain, that the structure, inside structure, how the structure's orientation is. Okay, aspect marker is this much. I mean, like, see, this is a simple, the picture is a rectangular one. If I do not say that which side is lateral and which side is medial, many times you will not be able to understand which side is medial and lateral. So that's why aspect markers is needed.
Okay, sir. Thank you, sir.
Okay.
Yes, sir.
And any other question?
Sir, my last question, sir.
Yeah, tell me.
Sir,
Last,
as you-
why last? You can go on asking me. I am happy to tell you.
Sir, you once told that you set up all the settings, sir, by yourself, sir, for musculoskeletal purpose, sir.
Yes, preset. You are talking about preset.
Yes, sir. You told that you.
Preset is what? Preset actually, it is not a very, what should I say? Doesn't work for all, but
Yes,
preset means when the engineer comes, no, he tells you that, okay, I give a usual setting. I make a usual setting for hip. I make a usual setting for shoulder. I make a usual setting for knee, like that. So you will adjust some gain, some dynamic range, and those things, those which we are not operating. Like, say, we are operating only depth, gain, and focus. These three things. But they will they will do something with the dynamic range also. Some other things also are there, grayscale and all these things. So they do those things, and they just say that, okay, this may be an average. I mean, for every average knee, this can show a good picture. Ultimately, your picture should have a very good resolution. But everyone's, I mean, they will give you a general knee preset, say, but it will not work for every knee. Someone's knee is thin, someone's knee is thick, so it will not work. But then it decreases your work. You just put the probe and just adjust the focus, depth, and gain. That's it.
yes. Sir,
This
in my
is
machine, sir, I have a machine here, and in my machine, sir, it is very difficult for me to distinguish between the tendon and the nerve, sir.
tendon
But
and nerve.
no, sir,
Difference.
when you showed here in the demo, I can very easily identify the
Okay.
nerve. But in my machine, there is a preset setting, sir, for musculoskeletal and superficial part. So I usually select that for my practice. So
See, in ultrasound, one thing I always say, in ultrasound is not such a modality that you will see first. You will put the probe and you will search for a structure. It is not I mean, it is not that type of modality. In ultrasound, always you expect a structure at some area. I mean, you should know the anatomy first very nicely, and you should know that, okay, nerve should be in that side. Then only you will see very nicely, and then it becomes very easy to differentiate between the structures. Of course, resolution matters. Resolution matters. Different machine is different. But if I do not know, I mean, if I have a confusion that where maybe the median nerve, I will search the area, then I will never get. I know that where it should be. It is just above the lunate bone. So in that way. And I mean, nerve and this tendon, nerve doesn't show that much of anisotropy. Tendon,
Yes, sir.
as I showed you in biceps tendon, black and white I can do, but you cannot do this thing with nerve. Honeycombing appearance with nerve you cannot see in tendon.
Yes, sir. Nerve
And
is marked, I
you
think.
can trace the nerve to a to nerve only. Nerve remains nerve only, becomes smaller or bigger, but tendon becomes muscle just after some time.
Okay, sir. Thank you, sir.
Okay. So all of you, I mean, see the, lecture recording and think about what we have taught. Otherwise, question will not come to your mind. Then only question will come. Okay. Thank you. Good night for today.